Good morning, everybody, and thank you for joining the action period call number 3 for understanding healthcare disparities and health equity in atopic dermatitis patients, building knowledge, confidence, and change in primary care providers. We are almost midway through wave 2 of this program, and it is going well so far. Can't wait to talk to all of you. Welcome. For those of you who can safely in the chat, please share your name and practice name, just so we have a record of it. But if you cannot do that, I will capture your name. So today's agenda item is the best practices collaboration. This is a good idea that they did in wave 1, and a good idea from the team in this wave to kind of bring it back. Have everybody be able to share their best practices, their ideas, things they've learned, have good conversation. We as the program team will be your moderators, and we as the program team also have the pleasure of talking with all of you, but the participating providers don't always get a chance to talk to each other. So we wanted to have a best practices collaboration in place for you guys to share the good things that are happening within the AD program. And if time is permitting, we're going to go over the aggregate data and reminders for the program. Okay, so this is the Atopic Dermatitis QI program best practices collaboration. And as an icebreaker, if you please could unmute and share a success that you have found since the beginning of the ADQI program. How have you successfully helped a patient and or their caregiver? If you don't mind sharing, we'll kind of get loose with this question.
Good morning. Can you hear me?
Yes.
Hi, I'm Pearl Hinden-Hain from Ironton, Ohio with Family Medical Center. And I have a 1-year-old who has had severe atopic dermatitis since just a few months of age and has just been miserable. I sent him up to Cincinnati. He was started on some triamcinolone, and they did some allergy testing on him, which basically came back normal except for eggs. And he was on hypoallergenic formulas and things like that. And she brought him in a few months ago, and he was just absolutely covered. Someone that worked at his daycare had actually, I see their patient, and they were very concerned because this kid was constantly scratching at his ankles and his wrists and just miserable at school. And so the mom happened to bring him in for a well visit, and she's like, I keep using all this stuff. I'm using all the hypoallergenic stuff. I just can't get his stuff under control. So I went to our little eczema action plan sheet and got it out, and we reviewed all of it. And I started him on the Desonide ointment and saw him back in 2 weeks. And I would say where he was probably covered about 75% of his extremities and his trunk, he was probably now down to about 35%. It was absolutely amazing. I never thought I would see him get that better. The other thing I did different was I put him on some hydroxyzine pretty much around the clock just to control his itching. And mom was just absolutely couldn't believe the changes. She said within 2 weeks that she could actually see his ankles and his wrists again.
Oh, that's wonderful. Any reaction from the team?
Yeah, it's such a great example and story on how we can make these patients better, and how much the eczema, atopic dermatitis really affects the entire family. I don't think I heard you well. Did he have any allergies?
Just to eggs.
To eggs. Okay. So that's that's also a really good point. Very often parents will come in thinking, oh, there has to be an allergy. There has to be some food allergy or environmental allergy or something. And even though patients with atopic dermatitis are more likely to have allergies, most of the time, even if they have an allergy, it doesn't have a lot to do with how the eczema is doing. And so it's something that we have to be very careful about, especially with infants, is that they're not on very restrictive diets when they don't have to. And we'll hear more from Dr. Stugas in one of our upcoming calls as well to kind of delve more into this issue of allergies. But it's great to hear that the action plan is, was helpful, and that's working. I was actually curious about that to see what you guys think of the eczema action plan. Has that been helpful for you? Has that been helpful for the families? Has it been easy for families to follow? Because that is one of the tools that we think that it's going to be much more kind of the go-to for the parents to use when they're at home. So I'm curious if what have you guys thought of the action plan?
Well, I personally really like the action plans. I think it really helps to have something in front of the parents that they can actually see, they can check off, they can actually see what they're doing and not have to try and remember all the steps from the office visit, because, I actually hand it to them. And after I make a copy myself, so I can remember what we talked about at the next meeting, and then we scan it in. But I think that and the little helpful hints, that we also give out that, they can, scan with their phones. I think all of that has been extremely helpful. And I have really incorporated all of that into my practice when I have kids, even like if they come in and it may not be so much like, just atopic dermatitis, but it may be like seborrhea or something like that I can say, here are some things that you can do to kind of help with the itching and things like that. So it's been extremely helpful for my practice.
That's wonderful. That's really great to hear. And I think you make a really good point. The goal, most patients fortunately don't come with severe atopic dermatitis, more are in the mild to moderate. And so, we really want all these tools to be used for any of your patients with some form of eczema, whether it's seborrheic dermatitis or atopic dermatitis or a contact dermatitis. Those are all kind of forms of eczema, and the same plan can be very helpful for all of them. So it's great to hear that you thought they're helpful, and that you feel comfortable in having such success treating your patients. That's wonderful.
Thank you.
Yeah, I was going to add that I found the written out eczema action plan really helpful. Yeah, especially once they start prescribing multiple creams and helping patients know yes, I prescribed you 2 or 3 different creams, but where do they go? When do I use one versus the other? They don't understand. Some of them, it's hard for them to understand oh, the triamcinolone is stronger than the hydrocortisone. They just think that they're all creams, or that they're different names, so they should be using both at the same time on the same body parts, that sort of thing. So yeah, I found that helpful. And as far as a win with one of my patients, I had a baby, I don't know how old he was, but maybe 9 months or so, but had pretty severe eczema. And so I, prescribed him some creams and things and saw him back for his next well check, but it was still just as bad as before. And I was oh, they didn't have the creams at the pharmacy, so I never got them. And doing some education about calling in if they have issues, and we can switch to the pharmacy. But we ended up sending it to a different pharmacy and had her follow back in a month, and filled out the eczema action plan for her, so she knew what to use when. And yeah, it had improved greatly, and itching was way better and everything too. So yeah, I think having that eczema action plan, and then just having to do more education about, the pharmacies and the meds and all that was needed. But yeah.
Yeah, that's great. Thank you for sharing. I think you bring up a really good point with the eczema action plan, and how to try to make it as simple as possible for the parents, because we can get really, really fancy and really complicated with multiple different creams for multiple different areas of the body, and we can make it really, really confusing. And really, eczema treatment is it takes a lot of time, and it takes a lot of effort. If you think about it, people tend to be not very compliant with taking pills, let alone trying to apply a moisturizer twice a day, doing baths daily or twice daily, doing 3 different creams on different parts of the body. It's a lot of work. So the more we can try to simplify it, or try to make it more straightforward for the parents, I think that the better we're going to be off, and we're going to get much better compliance for the parents as well. and the names are very confusing. You know, the medication names are very confusing, and it's very hard for the parents to follow that sometimes. Another important point with the names that you mentioned is that each topical steroid will have a different concentration spectrum, and so very often a parent will say like, oh no, I use hydrocortisone 2.5%, which is stronger than triamcinolone 0.1%, because they go by the concentration. And we have to educate them, well, no, that's not the case. Hydrocortisone 2.5% is actually very low potency. Don't look at the concentration that goes with each specific topical steroid, not the whole spectrum of the topical steroid. So that's another important point with the education of these medications, and how to deal with going to the pharmacy and not getting it covered. Are there other options? So that's definitely very important.
Thank
Hi,
you.
my name is. Go ahead.
please.
Sorry. Hi, my name is Dr. Baxa. I'm one of the attendings at the Indianapolis site. I just had a question about, and maybe this is just more for our site since this is our second round, but we're experiencing a little bit of fatigue from families with the eczema action plan, which I still really like and give to families. But those families that have gotten it multiple times now, and we may not be adjusting their plan too much, are starting to refuse getting them. I don't know if anybody else is experiencing this or has any suggestions or tips to kind of help guide us so we continue to have good support from our families.
Do you think these are parents that have come so much more familiar and comfortable with the eczema care that they maybe no longer need as much instruction or as much information to take home?
I would say that's the majority of our patients. The ones we're obviously more worried about, we're getting into dermatology. Though for us, our wait is more like 6 months, to be honest. And it's been kind of difficult to get in more of our moderate to severe cases in. So I think some of it is a frustration of knowing, and if in families we've already tried to get into dermatology and not getting in. But I think the majority are families who have had multiple children that maybe have gotten these action plans or already know what they're doing. So we're more just, okay, we'll take it with you anyways in case you forget. But they're starting to get a little bit fatigued from it, I think.
Yeah, and I think sometimes we can overload parents and patients with information and give them a bunch of handouts and a lot of written information. And sometimes the more we give them, the more it's going to get lost, and they're really not going to pay attention to it. So sometimes I think maybe just verbally going through the instructions and through the information, maybe they don't have to take the plan with them, but I think still kind of reviewing that plan and reviewing what to do. It's important at every visit. Sometimes they will notice things that they had not noticed before. So maybe they don't have to take their paper with them all the time, but I think trying to review the information at least with them before they leave, I think that's helpful. But yeah, I definitely take your point in that sometimes we overload patients with tons of information and they end up tossing the papers and not really reading through them.
I would agree with Esteban. I think that's a reasonable approach, right? Just kind of saying, remember, we gave you, your eczema action plan that we gave you at our last visit. If you need another copy, let us know. But I would agree. I don't think you necessarily have to print it off and give it unless you make major changes to it.
And I would say also, you can have them take a picture of it with their phone. Everybody has a phone. And just have them take a picture of it so it's not another piece of paper that they have to take with them. I'll address the issue. In Indianapolis, one of the pediatric dermatologists retired. And so the 6-month wait is not going to improve anytime soon. At IU, we're going to have a pediatric dermatology fellow, which will help open up a little bit, having some appointments, but it's going to be a problem for a little while.
Thanks for letting me know. That'd be helpful though, even to have a fellow come. I know we had a fellow at our site as well last year, and I don't believe we're filling again for this year. So it is making it a little bit more difficult for access for our families.
And Pat, I mean, maybe dovetailing on your comment on the photos, I think that's a really good point. And particularly with the medications, very often the parents will come back and we ask them, okay, we want to review what they've been doing, making sure that they have been using the medications correctly. And when you ask them, okay, which one are you using on the face and neck? And again, the names are very, very difficult to remember. And they would say, oh, the white and blue one, or the white and green one. And, unfortunately, the colors are not helpful at all. So we'll often tell parents just to take a picture of the medications of the creams, so we can talk about it and make sure that you're using them correctly. So that's another way to make sure that they're following the plan as we would like them to. When they bring the medications with them to the appointment, I think it's ideal, but that's not always possible. So at least taking a picture, that's helpful too, so we can make sure that they're doing everything the way we would like them to.
And
I
just a
run
little
into
note-
the same thing when the patients I say, which refills do you need? I need the one that starts with T. I'm like, okay, I need a little more information.
Yeah, and just a little note about everything we've been talking about, taking a picture of the action plan, maybe not giving them the paper, but going over it, talking about medication, all of that counts for the action plan on the data collection tool, and then the AD plan of care section as well. So make sure you're capturing the good work that you're doing. Okay, this is good conversation. Any other wins to share?
This is Robin in Cincinnati. I just wanted to share, I really like the action plan. I was terrible about giving people like written information. I would maybe jot it on a Post-it. It's terrible. And so I like being able to really write down the products that I recommend, because families will ask about that. And I like the section on face that's different. So you can really circle it, like don't use this strong steroid on the face. And then just little tips like file their nails short so they don't scratch at their skin. I like being able to like check the boxes and write in little comments. And I think the families appreciate it. They usually seem happy, at least the first time they get it, they seem happy to have like some written information to take with them. And then a win, I mean, this isn't anything very dramatic, but I did have a patient with papular eczema that hadn't been really clearly diagnosed before. On the arms, like near the elbows, and we're able to get it under better control with using a stronger steroid. They were just doing over-the-counter hydrocortisone because we weren't sure what it was, and so we were able to help him out. It was a teenager, and it was bothersome to him. So that after the lecture, it was clear to me when I saw him that, oh, this is what it is, and we can help with this. So that was a success for him.
Wonderful. Anybody else like to share or have any questions? Okay. Hearing none, this might be a good segue for how we started the conversation today, but prescribing, best practices around prescribing topical meds and communicating how much topical medication to use. We can pause here, but we do have additional slides with more information as well.
Brooke, I wonder if we should maybe quickly go through the slides, and that could maybe spark some ideas or questions.
Yep.
About it. So we had already gone through this information at some point earlier in the project, but we know there's been some questions about it, and we wanted to kind of address it again, since this is going to be a very important part of eczema treatment. So when we're dealing with eczema, we want to treat two kind of main pillars: is to try to address the skin barrier and address the inflammation. We know kids with eczema, their skin barrier is defective; it doesn't work as well. So we need to make sure we're addressing that, but at the same time, we're making sure we're getting the inflammation under control as well. Next one. So for the skin barrier repair, this is where the moisturizers really come into play. We want to use things that are simple, that don't have a lot of extra ingredients, not a lot of fragrance or no fragrance at all. We have to be very mindful of the formulation here. In general, for kids with eczema or atopic dermatitis, ointments or creams are going to be preferred, because those are going to be much more moisturizing than other formulations. So obviously, as long as the patient is open to using an ointment or a cream, then this would be the preferred formulations. There's definitely some preferences, some cultural preferences. Some people are really gonna prefer an ointment or even an oil. They're very used to, that's part of their kind of their daily or their normal practices, while other people are not going to be very accepting of an ointment or an oil. They would rather use a cream. So I think it's important to kind of talk about that and give those options and ask them, what do you think you're going to like better? A greasy ointment like Vaseline or a white cream that's not as sticky? So I think it's important to go over that to make sure that they're using the ones that they would prefer. Most of the moisturizers are going to be over the counter. And then the other part is the frequent baths or showers. We want them to be short, using warm water. Particularly teenagers, they like to bathe or shower with really hot water, and that tends to dry the skin even more. So we have to address that. We want to recommend some fragrance-free cleansers and really just kind of pat dry, not rub dry, and apply the moisturizer right after the bath or the shower. Next. And then to deal with the inflammation, the topical corticosteroids are really going to be our first line option to get the inflammation under control. We do have non-steroidal options that we use in certain situations, particularly if there's a lot of involvement, especially like around the eyes, for example. This is an area where we like to use the non-steroidal types, or where very sensitive areas are being affected. So we want to use the non-steroid type of option. So tacrolimus and pimecrolimus, these are the ones that have been out there for the longest. The brand names are Protopic and Elidel, which you might recognize, you might be more familiar with. The kind of newer ones, crisaborole, it's been out there for a couple of years. It's a phosphodiesterase 4, and then the newest one is ruxolitinib. This is Opzelura, which is a topical medication that's approved for 12 kids who are 12 years of age and older. For eczema, also approved for vitiligo. These two, the two last ones, those are they tend to be pretty expensive, and honestly, we are not even using them as much, mainly because of the access is very limited to this medication. But hopefully, they will become much more accessible as we continue to use them. Next one. One of the reasons why it's difficult to give like one recipe or one algorithm for which topical steroid to use where is that there's a lot of things that we have to kind of take into consideration. We have to decide on the potency, whether it's low potency, medium or high potency, what type of formulation, what's the vehicle, again, ointment, cream, lotion, which one are we going to use, what size of the formulation, which we'll talk about it in a couple of seconds. And then we have to consider what is the age of the patient. What are the areas that are affected? Is it mostly on more sensitive skin areas or thinner skin, face, neck, groin, for example, where we really want to stick with the lower potency medications, or maybe consider the non-steroid options here? Or is there more eczema, or also is there eczema on thicker skin, trunk and extremities, where we have more leeway of going to mid to high potency topical steroids here? And of course, we have to take into consideration, very importantly, the eczema severity. Clearly, it's not the same if we're treating somebody with very mild eczema or somebody with very severe eczema. And I think because there's so many factors that we have to take into consideration, it makes it really difficult to give like, oh, just follow this plan and you'll get there, or follow this algorithm or this recipe, and that will take you to which medication to choose. Next one. This is really a partial list of topical corticosteroids by potency. So the class 1 is the highest potency, class 7 is the lowest potency. There's a lot more, but this is a partial list that we had shared with you before. And something that I want to point out here, if you go to the next one, Brooke, please.
Yes.
There. Sometimes the formulation makes a difference in the potency. So if you look at triamcinolone here, even the 0.1% triamcinolone, same medication, same concentration, but if you go from a cream to an ointment, you go up on the potency. So sometimes the ointments are going to be more potent. That is not always the case. So be very mindful of that as well, which formulation you're using, not only for patient preference, but also because you might actually alter the the potency on the medication, depending on which formulation you use. And again, I just want to highlight here that the concentration is very specific to each medication. So it's important to explain that to the parents, because they think that if they're using, again, a 2.5% hydrocortisone, that's the strongest because it's the highest concentration, but that is not the case. Next. And then in general, we want to, again, keep the low potency topical steroids for the more sensitive areas, face, neck, groin, and we can use the mid to high potency for thicker skin, trunk, and extremities. Now, if somebody has very mild eczema on the hands, you can absolutely use a low potency topical steroid. You can always start with low potency and then go up as you need it. This does not mean that every patient with eczema on their extremities or the trunk, they need a medium or high potency. If they have mild eczema, they can absolutely get better and you can get under control with a low potency. But this just gives us some kind of more direction or more information on which ones to use where. Next. And again, here the formulation is going to be very important. The different formulations are kind of based on the concentration of oil. So ointments are going to have the highest concentration. That's why they're going to feel thicker and maybe a little bit greasier. Gels are going to be the ones with the lowest concentration of oil, sometimes even some alcohol in it. So those can be a little bit drying or irritating. So in general, for eczema, next, Brooke, we want to stick to creams and ointments. Those are definitely going to be our best friends for eczema. There is one topical steroid that comes as an oil, which I really, really like. It's a low potency, that's fluocinolone oil. So that oil formulation, it's really, really nice also for eczema. It's a little bit easier to apply. And even though it's an oil, it actually doesn't feel as oily or as greasy as you would think. So parents tend to really like that formulation. Next. And then, of course, how much of the medication we're going to give them. And that's a big question on how much of the medication we're going to give them. We want to give them obviously enough that is going to last them until you see them back, or to last them while the eczema is flaring up. We also use the formulation size to maybe limit the use, especially if we're using a much higher potency topical steroid. Maybe we don't want to give too much, because that's the way that we can control or prevent overuse of topical corticosteroids. Next. So this was a baby, and I showed it to you guys a few months ago, that I saw a 5-month-old with pretty much head to toe eczema. It was everywhere. And he was referred. He was given Desonide 0.05% ointment, which is absolutely, he had not been treated with anything before. Desonide is a low potency, so for a baby to start with a low potency is a perfect option. So it was the right medication, the right vehicle and ointment. But they were given a 15-gram tube, and the parents came and say, well, it helped for the 2 days that we were able to use it, but then we ran out of the medication. And an important part of the particularly the topical medications is that with certain insurance, even if you give them a refill, parents may not be able to refill it until that 30-day window passes. So they will not be able to fill it until the following month. So even if you give them refills, they may actually not be able to have access to that medication. So that's another important thing to consider. Next. So something that we can refer to is the fingertip unit. So basically how much on the fingertip of an adult we can use. So one fingertip unit equals to 0.5 grams. Now, we are not, when we're seeing patients, we are not trying to calculate, how many fingertip units this patient is going to need. That is, it's not like a practical tool for you to use in your everyday life. But this is to give you kind of a point of reference to kind of get a better sense of how much of the medication the patient is going to need. Next. So this is a chart that gives you a sense of how much an adult patient is going to need for daily application for 10 days. So for example, an adult is going to need a 15-gram tube for 10 days for daily application. And just kind of give you some reference points on the amount of the medication that they will use. Obviously, kids are different. We go to the next. And this will give you how much of the medication they're going to need for different ages, different body areas that are going to be affected. Again, I don't think it's practical for you to trying to be calculating how many FTUs the patient is going to need. I think what's important is for you to get a sense of roughly, okay, how big is a 15-gram tube? How big is a 30 or a 60-gram tube? How much are they really going to need for that month or for that period of time before you see them back in follow-up? Next. So for that patient that I told you about, really the 15-gram tube, if you go by that chart, is only going to last them for 3 days. So that's going to go really, really quickly. Instead, you could have given them a 60-gram tube that will take them for about 2 weeks. Now, in practice, what we would expect to see happening is that as the eczema starts to clear, then the parents are going to be using less and less. So that 60-gram tube will actually last a little bit longer. We would hopefully not expect that the eczema will be head to toe for the entire time. So as the eczema starts to clear, they're going to be using less and less of the medication, so they can stretch it out. They can stretch it out a little bit more and can last a little bit longer. Next. Oh, maybe we can take a break here, take a pause, and come back to eczema molluscum, which was another question that came up.
I had a best practice come in. I give the largest tube possible for topical steroids so they don't run out quickly. They get the most for their copay that way, but also cautioning them that more is not necessarily better when using it.
Correct. Yeah, that's a really good point. I think we have to educate the parents that we just need to use a thin layer. They don't need to kick their babies or their patients, their kids with this medications. A thin layer is enough. And I think particularly with lower potency topical steroids, it's safer to give a larger amount or a larger formulation. These are much safer medications to use. Where we have to be much more careful is when we are in the mid to high potency topical steroids, where we don't want them to overuse it or misuse the medications, or as we were talking before, we give them multiple prescriptions on the same day. They can get confused, and sometimes I've seen parents end up using, flipping the medications. They use the low potency on the hands and they use the high potency on the face. So we have to educate them again. So with the high potency ones, medium and high potency, that's where we want to be a little bit more careful with the amount that we provide. But with low potency medications, I would feel much more comfortable giving them a larger amount so that it can last them longer and get them through the until the follow-up visit.
I have a question for some of the on Epic. It'll show how many grams the tubes are normally that are offered, or the jars. So I feel like some of them only have 30 grams. It's the largest tube size, but then the next step is a jar, which is 450. I'm well, I don't think they need a whole jar, but they also, some patients might not actually go get refills and things. So can you prescribe, will the pharmacy fill multiple tubes at once? If you put in 120 grams or something, or I don't know how much that works, how often that works, or.
Yeah, that's a really great point. So the formulation sizes are super variable, and as you mentioned, one will jump from a 30-gram tube to a pound jar. So it can be very variable. So sometimes what I will do, let's say they might need 2 60-gram tubes, but there isn't a 120 gram tube, or the next one is too much. So you can write for either 2 tubes or 120 grams, and the pharmacy should be able to provide them with the right amount of the medication. So they will give them 2 tubes instead. Sometimes insurance companies have some limitations with that, but for the most part, at least in my experience, they don't. I do that a lot for patients who maybe their parents have shared custody, and so they go from one house to another, or maybe they spend a lot of time at their grandmother's house or somebody that takes care of them. So very often I will have the pharmacy dispense kind of double the amount, so they can have it for both households. I think it's easier if you prescribe double the amount than actually have them come for a refill sooner, because they might not actually be able to get the refill. And also the other part that we have to consider is that depending on the insurance, some patients may have a copay each time they fill a prescription. So filling it once for 2 tubes is better economically than filling one tube twice.
I completely agree. And I'm glad you mentioned the shared households, because that often is an issue. And you might think about that with your eczema action plan, is you might have to go ahead and give 2 copies so that the other household, the grandmother, the other parent will have the information. And particularly for moisturizers, even asking the caregivers at the daycare to go ahead and give the use the moisturizers. I usually tell the parents that they can keep the medications for them to apply, so they have control over that, but that moisturizers at the daycare are fine and can be applied multiple times a day. I'll go ahead and make another comment. When I'm giving lectures on atopic dermatitis, one question that comes up is, what's your favorite? And I absolutely have favorites, but my actual favorite is the one that the parents are going to use. So it's, I say my answer is the one that the parents are willing to use and the one that the child is willing to have applied. And so it's much better, even though I absolutely agree that creams and ointments are the best. If they have a lotion without alcohol that they're applying 4 or 5 times a day, that's better than the ointment sitting in the jar.
Yeah, that's a great point. I will often also recommend, the parent or the patient might not like the use of an ointment, but the parents say, well, but every time we use it, it actually gets better. So sometimes I will recommend, well, maybe we can use a cream during the day, an ointment at bedtime, then cover it with pajamas, and it's going to be better tolerated, and they will not get the sometimes the parents complain that they're getting their ointment, their Vaseline or their Aquaphor all over the furniture, and they're ruining everything. So we have to be kind of mindful of that as well. So you can also kind of mix and match, have them use a lighter formulation during the day, a thicker formulation at bedtime. Sometimes I will also have them mix them together. Sometimes I will tell them, well, sometimes the cream or the lotions can actually cause a little bit of a burning effect, especially if the eczema is being very active. So I will tell them to mix it with some Vaseline, mix it with some Aquaphor, so that it's a little bit thicker or a little bit more moisturizing than the cream itself.
I often hear that from the adolescents who don't want to use the heavier moisturizers on the face. And I completely agree with Esteban that you can have them use a lighter product during the day when they're going to school, and the heavier one at night.
I have another comment about that. The parents wanting to use the creams. I have a couple parents who are hesitant to use the steroid creams. They don't want their child to get used to them, or not be able to make it without the cream. So besides educational, the inflammation aspect of eczema, is there any other pointers of things you tell those types of parents?
Mm-hmm. Yeah, that's a very common concern from the parents, because they think of steroids as something that their skin will get addicted to, or their kid will get addicted to, and so that every time they're going to need more and more and more and more. That really doesn't happen with topical corticosteroids. So again, a lot of education really needs to happen there. And often what I'll point out to the parents is, it's one of you mentioned that when these kids have eczema, they are scratching all day long. They are not sleeping. And what I point out to them is that, well, if we don't control their eczema, their development is not where we want it to be. We want them to be concentrating on developing other milestones and not being scratching all the time. Or, we want them to sleep well so that they feel rested in the morning, and they will be able to learn and continue to develop their milestones through the day, and not concentrating on scratching and itching all the time. For parents who have more of those concerns, then that's where I think taking breaks from the medication is helpful. Sometimes I will tell them, well, let's use the topical medication, the topical steroid during the weekdays. Maybe let's take a break on the weekends. So they don't, in that way they will feel that they're not overusing it or using it too much. So taking breaks in those patients, I think, or those cases, I think can be helpful too. Still have them use it, still get the inflammation under control, but maybe kind of meet them where they are, and recognize that they have those concerns. And I think as they use it and they see how it works and how their skin and their baby doesn't really get addicted to the medication, they start to understand that that's the best way to get under control.
I have a quick question. If you have a patient who has severe, over their almost their whole entire body, and you're having to prescribe more and more of these, when do we start to worry about the absorption into the body with all the side effects? Because I'll have some people come in and they'll have just minor, eczema patches or whatever, and they'll come in and they say, I want an oral steroid because it works so much better and I get better relief and I don't have to worry with all the ointments and stuff like that. Why can't I just have that when my child flares and it's not that bad? And so then I have to talk about side effects of steroids. But when you have somebody, especially like this 5-month-old, in this picture, at what point do you say maybe doing some oral steroids to try and get it down so you're not using so much topical? And then when do you wean, and those type of things, if you have to use an oral steroid with these severe cases?
Yeah, that's a really, really, really good point. So with regards to absorption, so also a couple of factors that we have to consider. Of course, is a much higher concern in younger patients with a higher body surface area. But particularly when we're using higher potency topical steroids. With the low potency topical steroids, that becomes less of a concern. Yes, if we're using it every single day on the entire body, then there is a potential risk for absorption, although very rare to see actual systemic side effects or systemic effects of topical steroid use, particularly low potency topical steroid use. So in general, I don't have a lot of concerns with that. One important part is to always educate the parents to use the topical steroid on active inflamed skin and not use it as a moisturizer on normal skin. I think when we start to use it as a moisturizer or normal skin, which is obviously not the correct way to use it, that's where we can get into trouble with causing the side effects of the topical steroids, the stretch marks, the thinning of the skin, the blood vessels, things like that. So what I tell them to do is, as long as we're using the right potency on the right body side on active inflammation, then we're fine. If you're finding that is not enough to get their eczema under control, that either means, well, maybe we need to ramp it up a little bit on potency to actually get it under control, or do we need to start thinking about systemic therapy? The use of systemic steroids, we have to be careful with that, in the sense that, as you mentioned, it's not an adequate way to treat eczema long term, because obviously systemic corticosteroids long term have too many side effects that are not in favor of using them. One of the concerns in patients who have more significant eczema is that after using systemic corticosteroids, there can be a rebound effect. And sometimes what I tell the parents, sometimes it comes back with a vengeance. So sometimes that rebound effect is even worse than the initial flare. So that is something that we have to be very, very careful about. Also, the use of systemic steroids does not mean that then we don't have to use the topical steroids. I think those are actually parents or patients that I encourage to be very compliant with the topical steroids, because when they are done with the systemic steroid, then they're going to really need the topical steroid to prevent that rebound flare. So in general, if I can avoid using a systemic steroid for kids with eczema, I will try to avoid it as much as possible. But as you mentioned, sometimes these kids are just absolutely miserable and they need a quicker fix. And the systemic corticosteroids, we might need to resort to systemic corticosteroids. But I I make a point in having the parents not think that that is going to be the cure or that is going to be the treatment moving forward, mainly because of that rebound effect. And those are the patients that I'm very particular in telling them, as we're coming down on the systemic corticosteroids, then we really need to rely on the topical ones to prevent that flare from coming back. I don't know, Pat, if you have any comments on that.
I agree completely. And I also try to make to the point to the parents that you still have to repair the barrier. The steroids decrease the inflammation, but the barrier, you still have to repair the barrier. And so there isn't, oral steroids and no topicals that in terms of just the moisturizers. And so making that point that it's not a cure. And so I think keeping that in mind, that it's easier to give a pill than it is to apply moisturizer, but we still need them to do that.
Now, the good thing now is that we are having there's more medications, systemic medications coming to market to treat patients with atopic dermatitis. So a patient who has required, now we definitely see many patients who have gone through several rounds of systemic corticosteroids, not because it's been misused, but because their eczema is so severe that they have required that, or a patient has required hospitalization or multiple infections, multiple rounds of antibiotics. So now we have much better, safer systemic medications that we can use even in patients who are 6 months and older. So we're using dupilumab or Dupixent a lot more frequently. Not that every patient with eczema needs Dupixent, but we have better options now for these patients who can be very difficult to control.
And I guess I'll throw in a comment, sort of separate from the oral steroids, is when you are using the pound jars, first of all, the pound jars for moisturizer and the pound jars for steroids, is that I talk to parents about not double dipping, because with atopic dermatitis, there's an increase in infection. And so spreading it on the child and then dipping their hand back in. Most people understand double dipping.
Yeah.
With regard to foods. And so I do mention that, especially when you are giving pound jars.
Now, if we have to do a systemic steroid to get the eczema under control for patients who are very, very severe, what I do personally is I give them a taper. So I don't do like a 5-day Medrol pack, because that's kind of like high dose. And then I think those are the patients that tend to and then you stop cold turkey. So those are the patients that tend to rebound flare a lot more. So I typically give them a 10 to 15 day taper. So start with a higher dose, depending on the severity, maybe like a 0.5 milligrams per kilogram to start with, and then slowly go down in the next 2 weeks, so that their eczema gets under control, but we don't stop them cold turkey, and then there's a high risk of rebound there.
I have a question for you both, and this, Pat, I remember we used to do this a long time ago when I was in training. Is it still in vogue, or do you still recommend? I think we used to send prescriptions for sort of compounding, right? So I think I remember adding topical steroid to like Eucerin, and the pharmacy would do that. Is that still something that's done, or do you guys recommend more sort of the separate, just for dosing reasons?
In general, that is not something that I know that it's still being done. I know some people still do it, and I think they do it mostly from a practicality standpoint. Your moisturizer and your topical steroid are in the same formulation or the same jar, and so you can use it at the same time. I don't typically do that, and the reason for that is that I don't want the parents to overuse the topical steroids and think of them as the moisturizer. So I want them to have a very clear distinction between, this is your moisturizer. When the eczema is gone, keep using the moisturizer. And this is your topical steroid. When the eczema is flaring up, this is what I want you to use. So some people will use it, and it does make compliance better. It's just one less extra step. But in general, I tend to prefer not to use the compounded ones.
And I agree. I compounded more early in my career, and now I separate them for exactly the reason that Esteban said, that the moisturizer you want them to use every day, and the steroid you want them to use it when the skin is flared.
Additional thoughts, comments, best practices? Okay.
Another topic that we wanted to bring up, because I know this was a question at one of our previous calls, was what do we do with eczema and molluscum? So we see this all the time, and I'm sure you guys probably see it even more than we do. Molluscum is extremely common. One of the issues with eczema and molluscum is because the skin barrier is defective. The patient with eczema, their skin barrier is not great. It's not completely sealed. Then they are more likely to develop molluscum. So we see molluscum maybe much more frequently in patients who have eczema. Of course, patients without eczema can also have molluscum. So that is one point. The other point is that somebody who has eczema and molluscum, the molluscum can actually trigger a flare or drive a flare of their eczema. And it's either a regular flare of their eczema, or we call this molluscum dermatitis. So basically there's that irritation, that redness, scaliness around the molluscum bumps. This also happens in patients without eczema, but it's much more likely to see it happening in patients with eczema. And what I wanted to show here was, we've been talking about the different skin types and how eczema can look differently. So these are two patients with two different skin types. The patient on the left has a lighter skin type, and you can very clearly see that eczema flare on the antecubital fossa around the molluscum bumps. You can see that erythema, that redness very clearly. With darker skin types, that erythema, the redness is much more difficult to see. And you might see maybe just some darkening or hyperpigmentation instead of the erythema. Sometimes it just looks a little bit more violaceous or a little bit more purple, but both of these patients have this kind of molluscum dermatitis or flare with the molluscum. Next one is another patient also with a darker skin type, and you can see that the molluscum are very irritated, and the redness around it is a lot more subtle, and that is because of their darker skin type. So sometimes we also see the molluscum getting really inflamed in general. And then what happens here is eczema is very itchy. So they're going to be scratching where they have a bunch of molluscum. And by scratching where they have molluscum, that is a really good way that they auto-inoculate themselves with molluscum on other parts of their bodies. And so it's an issue. And also they are much more likely to get a super infection there if they also have eczema. So in general, and that'd be interesting to see what Pat's approach is, in general, when somebody comes with molluscum and eczema around the molluscum or molluscum dermatitis, I like to get that dermatitis under control first. Can I get the irritation under control, get the eczema under control, get the itching under control? Because if we don't address that, the molluscum is probably going to get worse as they spread around their bodies. Not treating molluscum is a perfect way to treat molluscum. So just let them do their thing and let them go away on their own. It's perfectly reasonable for these patients. Sometimes we use some topical medications, but the medications actually can make the eczema worse. They can irritate the skin a little bit more. So that's where we have to be careful. And that's why I prefer to make sure that we have the eczema under control first before even considering any treatments for the molluscum themselves. The next one is something that we see. I'd be interested to see if you guys have seen this or not, but these are patients with molluscum, but these are patients with giant molluscum. They're really big molluscum bumps. These patients all happen to have it on their face, but they can happen anywhere. And something that's interesting is that we see this here in Columbus. We have a pretty large population of African immigrants, particularly from Somalia. And almost always, the patients that will come with the giant molluscum are from Africa. Most of our patients from Somalia, but also from other African countries as well. When we see giant molluscum, we have to consider the possibility of immune deficiency, although all of these patients do not behave like somebody with immune deficiency, but just something interesting that we see in our immigrant population. I was kind of curious to see if you guys have seen that in other populations as well. Pat, do you see this in Indiana?
I have seen it. It uncommon. I agree that if you see the giant molluscum, then consider that there could be immune deficiency.
Any questions or comments about molluscum and eczema? Sure, you guys deal with molluscum all the time.
Could you just speak on like specific molluscum treatment? Like I know tretinoin sometimes, and I've heard of some other sort of like natural remedies too, but
yeah,
just...
there's a lot of things that can be used for molluscum, and what I tell parents is whenever there's a long list of treatment options for anything, that means that there isn't one thing that works the best or that works really well. We just have to kind of try different things. You know, again, just letting them run their natural course and letting them resolve on their own is a perfectly reasonable approach. If I need to, now typically when they get to us, that means that they're bothered by it, they're causing issues, they're causing problems. Usually the medication that I will use is a topical retinoid, either adapalene or tretinoin. There isn't great evidence to support the use of these topicals, but I think it's pretty benign and pretty safe to use these type of medications, and in many patients it will actually help. Other medications like imiquimod or Aldara, which is approved for genital warts, I think there's even less data to support the use, and some data to maybe discourage the use of things like imiquimod. I will use it very, very sparingly. So most of the time I'm using retinoids. These are patients, you know, we could also do destruction type of methods, either curettage or cryotherapy, although most of the time we're seeing this in toddlers or very young school-age kids who really don't tolerate these procedures very well. So I will not do this often in this age. I will do one of those destruction methods in older school-age kids or maybe young adolescents who are very, very motivated to get this over with, and they can handle those type of procedures well. But I often will not even mention that as an option because it's usually very, very uncomfortable. Pat, what do you do?
First of all your patients who are, all your patients who are shown here, I send them to ophthalmology because of the destructive methods and problems caused by destruction around the eye are better done by the ophthalmologist. I agree, those are the approaches I use. I think doing nothing, because they do tend to resolve on their own in some cases. What I say to parents when they have been told that they will tend to resolve on their own is that if they're multiplying, if they're in bothersome areas, such as the photos shown here, then to come back. And I think one of the earlier slides you showed had the inflammation. When there is inflammation, the term used in pediatric dermatology is BTE, beginning of the end. And so at that point, you can have the parents, if they want to apply a moisturizer, then those will tend to go away. I also will, on occasion, if they're scratching a lot and there's some secondary infection, use mupirocin when I'm observing that the lesions are on their way out, but use the mupirocin to try to help keep them from getting secondarily infected.
Mm-hmm. There's a couple of medications coming to the market, I think, pretty soon to treat molluscum. One is based on cantharidin or blisterbeetle component, so that will become available. I think pretty soon. We don't have it yet available, but that will become available.
Anything else from the providers? Okay, hearing none, and we're at time. I think it's safe to say that this can be continued. So stay tuned. Good conversation today. Thank you all for joining, and we'll be in touch. Thanks so much. Have a good week.
Thank you, everyone.